Alrighty. It looks like everyone can hear me, which is great. And I wanted again to thank you for taking your time to listen into this webinar. Today's topic is laser therapy for hip joint disorders. So I'm just going to, as always, do a bit of housekeeping. If you're unable to listen to the whole webinar, it is recorded and it's up on our support page, usually within a week of broadcasting. So you can always listen to it at any given time frame in the future once it's on the support page. And if you have any questions, I would love to hear them. Just type them in and I'll get to them at the very end of the webinar. And other than that, I think we'll get started. So I'm going to do a little anatomy review. I like doing this because, I used to teach anatomy for about 15 or 20 years. And even now it's been a while. So it's good to review some of the major structures. And it's just a good thing to go over. I'm going to discuss some of the most commonly treated hip joint conditions. These are the types of conditions that we tend to see as clinicians. I'm not going to go over all the hip conditions, just too many, but ones that will more than likely come across your plate at the clinic, so we can talk about that. And then, of course, we'll discuss how we approach treating hip joint disorders with BioFlex laser therapy, present 2 case studies so you can have an idea of how we sort of customized or changed some of the protocols based on their presentations. I think that will be helpful. And then lastly, go over any questions and answers that you might have. So from time to time, I just check questions out just to make sure that everyone can hear me okay. But I believe that everyone was hearing me okay. So okay, anatomy review. We all, of course, know the hip joint is a ball and socket, a true ball and socket joint. Recall there's a fairly large area on the head of the femur with hyaline cartilage, which, of course, is the major problem in osteoarthritis that we'll talk about as we go on. There's the ligament of the head of femur, which is cut. Recall that there's an artery that travels through that, a branch of the obturator artery that supplies some blood to the head of the femur. Recall the joint capsule. There's 3 portions to that we'll review very shortly. Of course, there's the acetabulum, which also has articular cartilage, a fat pad, and the acetabular labrum are the key joint-related structures of the hip joint. The joint capsule of the hip is extremely strong. Actually, it's the strongest joint capsule in the human body. Recall that there's 3 parts to it, the pubofemoral ligament, iliofemoral ligament, and ischiofemoral ligament that all form the joint capsule, which helps to stabilize the hip joint itself. Lots of muscles that are problematic in and around the hip joint from superficial to deep, of course, are the gluteus maximus, and deep to that, the gluteus medius and then minimus. And then we have the rotators of the hip, the obturator, brother and sister, inferior and superior gemelli, the piriformis, of course, and quadratus femoris, amongst others. And of course, the hamstrings and adductors all travel in and around the hip region. That was posteriorly. Anteriorly, of course, we have muscles like the tensor fasciae lata that can create hip issues, the rectus femoris, some of the adductor muscles, and of course, the iliacus and psoas or iliopsoas muscle, which create lots of difficulties in and around the hip joint. So lots of muscles to be concerned about. And when we're talking about hip joint disorders and laser therapy, this is probably one of the most challenging joints to treat because of the depth of the joint, the number of muscles that create a barrier for light to enter directly into the hip joint. So that being said, there's actually very little research on hip joint and laser therapy. And again, the reason for that is it tends not to respond as easily as other areas that you can get light to. So I'm going to talk about this as we go along. This is interesting because, we're familiar with bursae around the hip joint, but did you actually know that there's approximately 20 bursae in the trochanteric area of the hip joint, which is quite a few. Remember, bursae are found between moving parts. So literally between all these muscles and the tendons, lie small little bursae, or some of them are actually larger, to reduce friction in the area. And there's a few that we should really be concerned with because they tend to be the more common causes of hip bursitis that we see clinically. Blood supply to the hip joint is really interesting. Some joints in the human body have lots of blood supply, and others have very few or limited number of arteries or blood vessels supplying to it. And in the case of the hip joint, the major arteries you can see here are the lateral and medial femoral circumflex arteries, along with a very small, tiny branch of the obturator artery. So if these arteries are compromised, that is, if they're diseased or injured or what have you, then it can lead to avascular necrosis that we'll talk about as well. And we've seen quite a few of those cases as well. And it's actually not that uncommon a condition. It's something that everyone should be aware of. Light therapy can help, but again, it's quite a serious condition. So I'm going to be discussing arthritis, specifically osteoarthritis, because that's the most common arthritis of the hip joint. I'm going to talk about bursitis and the three most common forms of bursitis around the hip joint. I'm going to discuss labral tears that seem to be, again, fairly common. And lastly, as I mentioned, avascular necrosis or compromised blood supply to the head of the femur. So these are the conditions I'm going to focus on. Yes, I know there's a lot more than that, but given the time constraints, I can't possibly cover all of them. So let's talk about hip osteoarthritis. Recall that there's different grades or severity of osteoarthritis. The Kellgren-Lawrence classification uses from grade 0 to 4, 0 being normal, 1 being what they refer to as doubtful narrowing of joint space, maybe a bit of osteophytic lipping. So in other words, the joint space looks like it may be normal or maybe very, very altered or narrowed, and maybe start to see a bit of lipping and spurring. Then into grade 2, which is a bit more of a narrowing of the joint space, or at least possibility of that. And certainly you should be seeing osteophytes to get a grade 2. And then into grade 3, which tends to be what we see more in our clinic, which is a definite narrowing of the joint space. Of course, there are radiographic measurements that one can do to measure this. You'll be seeing moderate multiple osteophytes, some subchondral sclerosing, and maybe even some deformity. So by the time you get to grade 3, it's usually pretty symptomatic for these patients. And of course, by the time you get into grade 4, it's marked narrowing of the joint line, joint space. This is the category where people are going in for hip replacements or hip replacement surgery. So radiographically, just so you can review, you can see the joint line in a grade 1, which really doesn't look too bad, but you can see some whitening or sclerosing around the joint space, which is an indication of some earlier onset of osteoarthritis. Into grade 2, you see more sclerosing or the whiteness around the radiograph and a bit more narrowing, excuse me, of the joint line. And then into grade 3 and grade 4, grade 3, you can see there's only a millimeter or 2 of joint space. So there'd be marked hyaline cartilage degeneration. These patients are in quite a bit of pain, especially weight bearing, and probably symptomatic to the point where they're really seeking care. And then grade 4, where there's very limited motion, these patients should be having a hip replacement surgery at that point. So that's what it looks like radiographically. Of course, we're pretty familiar with the signs and symptoms of hip OA, so I won't spend a lot of time. There's going to be pain and typically stiffness in and around the hip, groin, gluteal region, or even the back or the thigh region. Sometimes patients also talk about knee pain. So you do need to make sure that there's not actual knee condition going on, but it's not uncommon for patients to be having referred knee pain as well. Typically, their discomfort is most noticeable when they're getting out of bed in the morning, that gelling of the joint overnight. Crepitus is common and it's usually painful. Remember that crepitus is quite common in many joints, but if it's not painful, it's not usually too much of a concern. It's when it starts to become painful that it's more indicative of an osteoarthritis or degenerative type of condition. Patient is oftentimes limping, may require a cane or supportive use. Of course, their range of motion is being decreased. and their function is also going down. And inactivity tends to make it worse. So these patients do respond well to activities like aquasize, cycling, anything to move their joint around and not too much of a weight-bearing mode is quite beneficial for them. So you should be encouraging that as well too. Hip bursitis. So there are several, I mentioned actually there's about 20 bursae around the hip area, but the ones that we're most concerned about are the iliopsoas bursitis, which refers pain anteriorly in and around the groin region. Of course, that's where the psoas and the iliacus muscle are coming down towards its common insertion. The trochanteric bursa or trochanteric bursitis, right overlying the greater trochanter. So again, bursitis tends to cause localized pain with some referring pain around the region, but you're not going to see trochanteric bursitis pain around the SI joint, for example, or traveling down into the thigh too far. It tends to be isolated, and you can usually palpate a specific area that correlates with that actual bursa being inflamed. And ischiogluteal bursitis as well, which, as you can see the location there, more along the gluteal fold. Okay, so you need to know what you're dealing with. When we approach treating bursitis around the hip, we're not going to use the entire hip protocol. You can use one or two placements with the hip protocol. You can even customize it to maybe reduce the amount of time, mainly because these bursa tend to be a bit more superficial. Well, at least a trochanteric bursa anyhow. The ischiogluteal and iliopsoas, you might want to stick with slightly longer treatment times as are in the hip joint protocol. But you don't need to treat away from the area or all around the hip joint if it's a specific bursitis condition that you're dealing with. The hip labrum is a piece of cartilage that surrounds the acetabulum. You recall that it's held in place by the transverse acetabular ligament. Its functions include shock absorption, helps to lubricate the joint, pressure distribution, and aids in stability of the hip joint itself. Labral tears are relatively common. They can occur with trauma, typically, but not always. They can occur by overuse. And through other disease processes as well. They're oftentimes associated with wear and tear of the hip joint. They can be radial flap tears. Oftentimes you get that flap impeding joint motion so that the patient can't move their hip very well, or it's blocked, similar to a meniscal tear that's floating around in the knee joint. Radial fibrillated tear, which is kind of more like degenerative tearing of the labrum. And peripheral longitudinal, where the labrum and the chondral bone area separates. So there's different types of labral tears, and it's important to understand what's going on there in order to have a better idea of a prognosis. Radial flap tears being not that great a prognosis without surgery, and oftentimes the peripheral longitudinal as well, if it's quite involved, might also require some stitching and surgery as well. Signs and symptoms of hip labral tears. There's typically anterior hip or groin pain with these patients. It's less commonly in the buttock, but it can be painful there as well too through referral. Frequently, there's also mechanical symptoms, as I mentioned, perhaps clicking or locking or even the joint giving way. So these are all possibility of signs and symptoms of labral tears. Hip avascular necrosis or AVN. The issue here is decreased blood supply to the actual head of the femur. And I mentioned earlier the blood supply of these three arteries that supply that area. So there's only limited blood supply. When one or more of these arteries are damaged, either through the trauma or disease processes, then the ability of the bone cells to thrive are decreased, and you'll get eventual deterioration of the hip itself. So really, it could be a fracture, a dislocation, as far as trauma goes, that could create a problem. Perhaps even falling from a height, like off a ladder onto your feet, can jam and damage the hip joint and the blood supply as well. It's not uncommon for the symptoms to take a while to manifest as the necrosis slowly begins, and it can take a couple months or even up to 1, maybe even 2 years to develop following an actual traumatic injury. There's other risk factors, including it can develop due to excessive corticosteroid use, not so much occasional cortisone shots, but more ongoing corticosteroid use, maybe due to, being used for rheumatoid arthritis or other systemic conditions. Smoking causes overall blood vessel constriction, which again is not great for this joint area. Excessive alcohol can be a problem. It can actually damage arteries as well too. So these are all risk factors and possibilities that may cause AVN to develop. So it develops in stages. You can see these stages in front of you from stage 1, 2, 3, and 4, where you eventually get collapse of the femoral head in late stages. The first symptom of AVN, it tends to be pain with weight bearing. And then over time, this can progressively get worse. The pain tends to refer into the groin and or the gluteal region and down the anterior or front portion of the anterior thigh. As the symptoms progress and the condition progresses, the pain will not just be with weight bearing, but also at rest, and oftentimes interferes with the patient's sleep patterns. So that's a progression over a period of time. Okay, so let's get into how we're going to approach BioFlex treatment. The standard protocol or treatment, or placements for the arrays, I think everyone here is familiar with. We want to treat the anterior portion of the hip. So you can see here under A, the array is placed such that if the patient can, open up their hip a little bit and make sure it's supported properly with pillows, and apply that first array so it's overlying the anterior portion of the acetabulum. Okay, it's really important that you get that location correct, so make sure that's established. Then a lateral placement, which shows B, over the lateral acetabulum and I guess a portion of the greater trochanter, depending on how you place it. And then thirdly, a posterior position, again overlying the posterior portion of that joint. So we want to surround the entire joint when we're treating a joint-related problem. So with the exception of bursitis, these other conditions like osteoarthritis, labral tears, avascular necrosis, we're going to use all three of these placements around the hip joint. The protocol itself is quite involved, and by that I mean the time frame. So if you look at the time of the dual red array and the dual infrared and even the laser probe, it's substantially higher or a longer number of minutes per area than, say, the neck or the shoulder or the knee. And again, this really has to relate to the amount of blood supply that we're trying to treat. Remember that a big portion of the red and infrared treatment is to stimulate white blood cells that are circulating in and around the joint that we're treating to help them decrease inflammation. So you're trying to activate and immunomodulate what the circulation system. And so given the joint is so large, we do need longer time frames, like 8 minutes and 10 minutes, or even sometimes even longer, to have a good effect of the blood going into the hip joint. Notice that the LDI 200 is 10 to 12 minutes. So a little bit longer than around other areas. You'll want to treat all the way around the joint. So 2, 3, 4 minutes around the anterior, lateral, and posterior joint. And depending on the area most involved, you might want to spend an extra minute or two on that specific area. So for example, if it's an anterior labral tear, spend a bit more time over that anterior joint area. Make sure the hip is in open pack position as best as possible and make sure you push the probe in to allow that light to penetrate as deep as possible. Then as you can see, let me just backtrack a bit. You can see that the frequency and duty cycle is fairly high to start off with. For the infrared at 50 to 70, you can even start at 50 to 90. In that range is adequate. And again, we're being a bit more aggressive because of the size and the number of muscles and tissues overlying the hip joint. Stage 2, starting to modulate the red light 190 and modulating the infrared a little bit higher to 250 frequency, going to maximum duty cycle. So maximum power for the infrared at 90%. And same thing with the probe. And then by stage 3, we're starting to really fluctuate the frequency at a much higher level. So that's the standard hip protocol. You're going to use this protocol for all those conditions I've mentioned, whether it's a AVN, osteoarthritis, labral tear, even a bursitis, although the exception might be a trochanteric bursitis, in which case you could probably tone down the time from, say, 8 minutes and 10 minutes to maybe 7 minutes, 9 minutes, or something like that, is fine because it's not quite as deep as some of the other bursa that you're treating. So some treatment tips that we recommend. These patients do require consistent care, so treat them at least 3 times a week for several weeks, or at least until you're finding that they're starting to make good progress, at which point you can go down to twice a week. The laser probe, again, I already mentioned you're going to use at least for 10 plus minutes, 3 to 4 minutes over anterior, lateral, and posterior parts, not ports, of the hip joint. In many cases, there might be back problems as well that's creating problems, so make sure you examine the back and treat that if necessary. For stage 1, the LDI 200, which I obviously did a good job of spell checking here, is set at 70%, but you can start even higher and you can progress to 100% fairly rapidly. So within 2 or 3 sessions, you should easily be able to go to 100% power. We don't usually use the red probe for hip joint disorders, just given the depth of the condition. The red light's not really going to be penetrating very deep, and the pain is really located really deep. So it's not overly effective for the hip joint. So again, I always like to remind everyone out there with respect to depth of penetration and active depth of penetration. So let's say we hold the infrared probe for 1 second. Well, that light can penetrate, depending on the tissue, maybe up to 3, 4, maybe even up to 5, 6, 7 centimeters. So let's say this is where my arrow is here, the depth of penetration after 1 second. However, even though there's light traveling to that depth, more than likely there's not enough light to activate or cause an effect at that depth, which is why we need to hold it for longer and longer and longer to intensify the dosage at that greatest depth that we're after. So in other words, if we're trying to get light into as deep as possible the hip joint, you're going to want to hold it for at least 10 seconds, if not 15 seconds or longer at one spot. So much longer than you're going to hold it for the neck or even the shoulder. So if you're not doing that, you'll find that you'll get better results if you actually hold the probe and depress the probe into the tissue as best your patient can tolerate to allow that penetration to be even deeper. I can't emphasize this more because it's really critical to get good results. All right, that leaves me a few minutes to go over 2 case studies. One is a case of osteoarthritis and osteonecrosis. I won't spend a lot of time on the history, other than it was a 59-year-old electrician. He had an injury a couple of years ago, also a really old soccer injury as well that he had. And some of the physical examinations, he's having decreased range of motion, some tenderness, that kind of thing. And an X-ray revealed that he did in fact have osteonecrosis at the femoral head, and there's some subchondral lucency and sclerosing and mild collapse of the articular surface. So he is in the grade 2 category of avascular necrosis. So it wasn't the worst prognosis. We were able to actually help this patient. So we started off, you can see here, 8 minutes of the red continuous wave, 50, 80. A little bit higher than what the standard protocol as far as the percent duty cycle, 10 minutes in the 3 areas, and then using the LDI 200 at 80% for 10 minutes in and around that area. After several treatments, we made some changes, increasing the duty cycle and the infrared to 90 and increasing the power of the probe up to 100%. And then as we've progressed, you can see that we actually start to increase the time of the infrared. We slightly decreased the red. Again, the idea here was the patient was responding, but not optimally. And we wanted to do whatever we could to get as much light as possible to the deeper blood vessels, to the deeper areas of the in and around the hip joint. And we also we increased the time of the probe as well to 14 minutes, again, to try to get more light into the joint. So remember that you can customize or make these changes as the patient goes along. If you're feeling you need to add more time or take away time to a different area, this gives you an indication of how you might do that and why you might do that. Treatments 15 to 20 were modulated the infrared to 250. Sorry. And after about 20 treatments or so, the patient had responded fairly well. Of course, that condition was a progressive one. It did stabilize. That patient was able to, it didn't have surgery. I didn't see a follow-up on that patient, but when he left our care, he was actually doing fairly well. So at that point, anyhow, we felt that we had plateaued and did as much as we could for him. However, we did recommend that he come in for maintenance treatment on an ongoing basis. And I know he had some appointments set up with his orthopedic surgeon as well, too. So unfortunately, I don't have the follow-up on that. Case 2, a 53-year-old female martial arts instructor. She's having pain in her left hip and inguinal region. Note that region. Her symptoms began 2010 insidiously, but you have to remember that as a martial arts instructor, she was doing a lot of different movements and trauma, in a certain way to her hip. So more than likely it was something that happened when she was instructing or even competing. Recently, she had become more acute in pain and was doing some physio and was taking Celebrex. Unfortunately, it wasn't helping her when she came to see us. And at this point, she was having a real struggle with maintaining her ability to instruct in martial arts. You can see the physical examination findings. Her straight leg raise wasn't too bad, but she was having limitations of internal rotation and some other motions as well. Bit of issues in her lumbar spine as well. And some tenderness in around that region as well. Motor and neurological was normal. So off for an MRI, and that came back as a tear of the left labrum. So we had already treated it, started treating by that time. We approached the treatment similarly to the previous protocol at 8 minutes and 10 minutes, 50-70. So similar kind of scenario. From there, we went up to 50-90 for infrared. Again, the LDI 200 was at 12 minutes. So again, fairly long at 100%. We then got up to treatments 11 to 16, 250-90. And she was responding quite well to that. We finished off well over 20 visits. You can see we actually started to modulate the red up to 1090, when started to modulate the infrared a little bit higher to 250-90. And we got her to a point where she was actually able to return back to work. She still had a bit of issues, but her range of motion was such that she was able to go back to instructing without too much difficulty, and we were able to stabilize it. We didn't do a follow-up MRI, at least that wasn't ordered. However, based on her range of motion and her signs and symptoms, we felt that we had reached maximal medical recovery. So these last two cases, these aren't your standard osteoarthritis. These are conditions that are very challenging to treat. You have to be prepared that your treatment plan is more than just 10 or 15 sessions. It might be 20 or 30 sessions. It might be ongoing maintenance. And it might be ended up with a trip to the surgeon. It really depends on how severe the labral tear is, or the advancement, or if the AVN progresses. So all these things need to be taken into consideration when you're treating hip problems. Just bear in mind the treatment times are extensive. The time that you hold the probe is much longer than standard, and that these patients aren't going to have remarkable recoveries in just a handful of sessions. And so everyone needs to be on board with that as well too. Oh, sorry. There are treatments 23 to 30, and you can see we modulate the infrared as well up to 500. So she had quite a few sessions with us. Okay, we only have a few minutes left. A reminder that we do have a July training, 21st and 22nd here in Toronto. If you happen to be in the States or want to visit Virginia Beach, we have one planned for August the 12th to 13th. Hopefully you can make it out to see us then. Now, any questions? So let me see if we have any questions. By the way, these questions are usually recorded, and they are usually on my edited version on the broadcast, on the support page. So I think there was one time we missed doing that, but we're trying to include that so everyone can listen to these questions. So I have a question. Patient has chronic pelvic pain and some lower back pain, not necessarily joint related, and responded to trigger point for only short-term relief. And Haroon has been using lumbar and hip protocols, which has been helping to some degree. So as far as chronic pelvic pain, that's where the diagnosis is pretty critical, Haroon. I'm not necessarily sure what's causing her pain or this patient's pain. So I think it's something that you probably have to have maybe some diagnostic imaging to really get a handle for that. Deep pelvic issues can be problematic as well, just because of the depth that you're trying to treat. So be aware of that as well too. Can you describe what has been called a hip pointer? Well, my understanding with a hip pointer is more of a contusion type of injury. For that, you probably still would use a hip protocol because of the depth of the muscle that that's being treated, but they should respond fairly quickly. So hip pointer, a contusion type of thing, should respond well to 6 to 12 sessions, Jeff. I know we've seen a few here in the clinic, and they've done usually pretty well. A question from Jill. And Jill, I think you sent me an email, which I will get to later today. With stage 4 osteoarthritis, is there a point in doing laser or just wait until the surgery and do it after? Time and cost of laser would likely be prohibitive with this joint this far gone, or would it be? Actually, Jill, you know what? Interesting enough, we've treated patients in stage 4, basically waiting around for the surgery, and we've helped them substantially, not necessarily to avoid surgery, but to make their pain and the amount of meds they're taking and so forth reduced. And they've responded quite well to the surgeries. In other words, they seem to heal even better than had they not had that surgery. So what I would say is that it's really good palliative care. Okay, so, depending on costs, issues and all of that, but end of the day, if they want the best outcome for the surgery and if they want to be helped with some degree of their symptoms, because it will reduce the inflammation, I would say, and I would recommend to treat them even at stage 4. If a patient is returning after some time for continued treatment, can you start where you left off, or should you dial it back and start at the beginning settings? Good question from Zara McDonald. What we tend to do is when the patient comes back for continuing treatment, if it's not a acute flare-up, we'll go back to roughly the stage 2 setting, not right back to stage 1. If it's a really acute flare-up, maybe go back to stage 1. But if it's kind of maintenance, that kind of thing, sort of the midway point of your protocols is a good place to start. And how do you differentiate between labral tears and just OA? I think other than the presenting signs and symptoms, Doug, perhaps I think the MRI is a definitive test. There's some orthopedic tests too, I think, for labral tears, but they're not definitive. So it would be hard to say unless you had MRI imaging. And who's the cat? I don't know who the cat is. So anyway, thanks everyone for tuning in. Much appreciated. We'll see you next week or next month, not next week. Take care.